All right, welcome back to the PMHNP Podcast. We're going to go ahead and get started with talking about FDA, what it is, and then how we get into the black box warning and what medications go with it as we take a closer look at this really important area. So here are some of the topics that are going to be covered. What is the FDA? Drug regulation processes, defining a black box warning, importance and determination of the black box warning. We're going to look at some examples in psychiatric medications. And then finally, just our key takeaways for the safe prescribing of a black box drug that has a serious warning associated with it. So first up, let's talk about what the FDA is. So this is the United States Food and Drug Administration, or the FDA. It's a federal agency under the Department of Health and Human Services. This is responsible for protecting public health and ensuring that the safety, efficacy, and security of humans and veterinary drugs is established. We also look at biological products, medical devices as well. It also regulates the food supply, cosmetics, and radiation-emitting products. All right, so the responsibilities of the FDA as far as it is related to drug regulation. So first we have the preclinical testing that takes place. So this is the drug safety being assessed in animals before it goes on to human trials. Then we look at clinical trials. This is your phases 1 through 3. We see new drugs undergoing rigorous clinical trials to evaluate the safety, efficacy, and appropriate dosing of that medication. New drug application, or what's known as the NDA review. This is where the FDA reviews that clinical trial data before approving a new drug for public use. Then we have post-marketing surveillance. This is our phase 4. So even after the approval of the drug, the FDA is going to continue to monitor for adverse effects and safety concerns. And this is going to happen through something called the MedWatch system. And then finally, we have the regulatory actions. So if a significant safety concern emerges, the FDA may do one of 3 things. We can require a black box warning. They can issue a risk evaluation and mitigation strategy, what's also known as the REAMS program, or we have to withdraw the drug from the market if it becomes necessary. All right, so what are black box warnings? So a black box warning, this is this is really the strictest warning or regulation that you can get from the FDA, and it's going to require a prescription drug. So it indicates that drugs, this particular drug or drugs, carry significant risk of serious or life-threatening adverse effects. So the black border around the warning in the prescribing information, or the PI, this is going to highlight that critical safety concern for you as the healthcare provider. All right, so why are they important? What's the reasoning behind these black boxes? So first of all, we're going to enhance patient safety, right? So this alerts providers to the potential fatal or disabilitating effects of that drug. We're looking at guiding prescribers here. So this is going to help inform us about necessary monitoring, contraindications, or some type of risk mitigation or minimization that's going to be needed, and what type of strategies we can use. Third, we're going to be looking at preventing medication errors. So this is going to help educate you, the clinician, on proper use, dosing, and patient selection. Informing the patients is going to be a key part of this, so it helps patients understand the serious risks and encourages them to share in the decision-making process and be a part of it. And then we're looking at supporting evidence-based practice. So this is going to help you, the provider, use up-to-date safety data from post-marketing surveillance. So how are black box warnings determined? This decision is based on evidence, right? So we're going to rely on that clinical trial data, or that pre and post-marketing information, adverse reports. So MedWatch and other databases are going to help supply this reporting that's going on by patients and the providers. Post-marketing studies, again, this is going to be your phase 4 trials, expert advisory committee reviews, and then we're also going to have epidemiological studies. This is going to help detect rare but serious effects. So some of the common reasons that a black box warning is issued by the FDA are going to include, first and foremost, life-threatening risks. So this is going to include things like QT prolongation, respiratory depression, or even fatal overdoses. We have serious psychiatric effects that can occur. So some of these drugs are going to cause things like suicidality or hallucinations, or can even lead to violent behavior towards themselves or others. Then we look at severe organ toxicity. So things like hepatotoxicity, nephrotoxicity, and neurotoxicity can occur. We also have birth defects. This is also known as teratogenicity. So this is where we have potential harm to fetuses, and it may require some type of pregnancy warning. Severe drug interactions. This occurs when we have those CYP450 enzyme interactions. We have CNS depression or something like serotonin syndrome or Stevens-Johnson syndrome. Finally, we have abuse and dependence portal or potential. So this is where we have high-risk medications. They're going to be subject to DEA scheduling, and it's going to require risk mitigation strategies through that REMS program. All right, so what are some examples of psychiatric medications? We're going to go through those now and talk about each one of them specifically and give you clear indications for use or not using, as well as go over a clinical case study for each one of these. All right, so first up, we're going to talk about the black box and rationale for antidepressant use, especially in younger individuals, 24 years and younger. All right, so a little bit of background here with antidepressants. Um, in 2004, the FDA issued a black box warning on all antidepressants after meta analysis of clinical trials suggested an increased risk of suicidal thought and behavior in individuals equal to or less than 24 years of age. So the warning was updated in 2007 to include more specific guidance for you, the healthcare provider, the patients, as well as caregivers. Studies found that 2 to 4% of children and adolescents taking antidepressants experienced increased suicidal ideation or attempts, though no increased suicide rates were found in these studies. So, risk appears highest in the first few weeks to months of taking the antidepressant after starting treatment or when there is some type of dose adjustment occurring. So the clinical implications and really what do we need to look out for as a prescriber are going to be first and foremost, we have to screen for suicide risk before prescribing the antidepressant, especially in the younger population. We want to monitor patients closely for any worsening depression, behavioral changes, or any type of emergent suicidality, particularly within that first 4 to 8 weeks of treatment or any time following a dose change. We want to educate patients and caregivers about the warning signs, and this is going to include agitation and weakness, new or worsening anxiety, hostility or impulsivity, and then unusual changes in mood or behavior. Finally, we have to do this risk benefit analysis where we weigh the risks versus the benefits. So, untreated depression also increases suicide risk, right? So, making it crucial to assessing this individualized treatment and making sure that we're giving them the best options available, even though there may be warnings that are attached to it. So, the classes of antidepressants that are affected here, first, we're looking at selective serotonin reuptake inhibitors or SSRIs. This is the most commonly prescribed antidepressant due to efficacy and really that lower side effect burden or profile compared to the older antidepressants. We see some of the common SSRIs with black box warnings, which they're all going to have here. So, fluoxetine or Prozac. Now, this is the only SSRI approved by the FDA for depression in children less than or equal to eight. I'm sorry, greater than or equal to 8 years of age. So, 8 years and older can receive Prozac for depression. Sertraline or Zoloft. This is approved for OCD in children equal to or greater than 6 years of age as well. Escitalopram or Lexapro, approved for major depression in adolescents equal to or greater than 12. Paxil. Now, with Paxil or paroxetine, we do have a higher risk of withdrawal symptoms and suicidality, and it's not recommended for pediatric use. Then we have fluvoxamine or Luvox. This is an FDA-approved medication for OCD in children equal to or greater than 8 years old. And then finally, citalopram or Celexa. We have limited pediatric data associated with this drug, so it's only used as off-label in some specific cases. Next up, we have serotonin norepinephrine reuptake inhibitors or SNRIs. So these may be more activating, which can increase anxiety and restlessness. So you want to be watching out for that in your patients because it may be, it may exasperate the symptoms that they're already having. And some of the common SNRIs with the black box warning that we'll talk about here, first of all, it's going to be Effexor XR, venlafaxine. So this is associated with higher rates of suicidal thoughts in youth. We have duloxetine or Cymbalta. This is approved for generalized anxiety disorder or GAD in children equal to or greater than 7 years of age. And then deslovenlafaxine or Pristiq used in adults. This has got really limited pediatric data. All right, next up are going to be our tricyclic antidepressants. And with the tricyclics, this is an older antidepressant with higher toxicity and risk in overdose. So it's rarely a first line treatment for children or adolescents, and even adults for that matter, due to the cardiac risks that are associated. So some of the common TCAs that you'll see are going to be amitriptyline or Elavil. So this is used off label for pediatric depression. There is a high risk of QT prolongation. Nortriptyline, this is used in adolescents, but it's uh, definitely used with caution in this population. All right, and then imipramine. This is approved for bedwetting or enuresis in children. It's not approved for MDD in children. And then we have anafranil. This is approved for OCD in children greater than or equal to the age of 10. So, what are some of the risk mitigation strategies that we utilize with antidepressants? So, first and foremost is going to be patient and family education. So, we have to provide a medication guide detailing the black box warning. You want to do it verbally and in written form. You want to encourage open communication about any type of mood changes that we might see. We want to discuss the realistic treatment expectations, right? Emphasize that you're not probably going to see any improvement until at least 4 to 6 weeks after starting these antidepressants, and then frequent monitoring. So weekly follow-ups for the first month, then bi-weekly visits for the next 2 months, and then monthly checkups thereafter. So, some of the alternative treatments that we can utilize as a risk mitigation strategy would be the use of things like cognitive behavioral therapy or CBT. And then there's a ton of other psychotherapies that you could also use. And these could be your first line treatments for mild to moderate depression in younger patients and even older patients as well. Then we have a combination therapy. So, this is your medication plus therapy. This has better outcomes than just medication alone. Okay. So, some of the summary and key takeaways with antidepressants. All antidepressants are going to carry that black box warning for increased suicidal thought and behaviors in those equal to or under the age of 24. Risk is highest early in treatment or after the dose changes. Now, Prozac is the only SSRI FDA approved for pediatric depression ages 8 and older. We have Paxil that should be avoided in children due to higher risk of withdrawal and suicidality. And then we want to monitor closely for mood behavior changes, particularly during that first 8 weeks. And then finally, therapeutic alternatives like CBT or family therapy should be considered anytime you're talking about medicating somebody for depression or anxiety or other indications for the antidepressant. All right, so let's take a quick look at a case study involving suicidality when on an SSRI. So, our profile here, we have Alex M. He's a 16-year-old male. Chief complaint is, I feel hopeless all the time. I don't enjoy anything anymore. Some of the history is Alex is a high school junior, presents with persistent sadness, loss of interest in activities, irritability, fatigue, difficulty concentrating, and disrupted sleep for the past 6 months. Now, his symptoms have worsened over the last 2 months. This is leading to a decline in academic performance and social withdrawal. He denies any previous psychiatric history, but his mother reports that he has become more withdrawn and also short tempered. So, no medical history is contributing to these situations as you assess. And then the family history can include maternal grandfather with major depressive disorder and no known history of suicide attempts or psychiatric disorders within the family either. He's not on any medications, substance use, denies alcohol, tobacco, and illicit drugs. So some of the safety concerns, no suicide attempts, but there have been passive suicidal ideation. Things like he's reporting, I don't want to wake up some days, and he doesn't have a specific active plan about it, though. So what do we do for this patient given Alex's symptoms? So he also has functional impairment here, right? So we're going to want to help this kid. Fluoxetine or Prozac could be a good starting location at 10 milligrams daily. Um, Now, keep in mind, this is the only SSRI that we can utilize. We could also, well, that's not true. We could potentially utilize another because he is over the age of 12, but oftentimes we will start with Prozac. Now, his mother was provided detailed education on the black box warnings and is instructed to monitor any worsening of suicidal thoughts, agitation, or the unusual behavior, particularly in the first few weeks. And then a follow up appointment is scheduled in 1 week with a plan to increase the dose at that time if necessary. All right. So, good example there of how we utilize an SSRI in the younger population with that black box warning associated with suicidal ideation. All right. Let's go ahead and move on here. We're going to talk about some of the atypical antidepressants and their black box warnings. This is going to include atomoxetine and bupropion. So, atomoxetine, or what's known as Strattera, this is known to have an increased risk of suicidal ideation in children and adolescents as well. So let's talk about some of the key background and rationale for this. So Strattera, this is a non-stimulant selective norepinephrine reuptake inhibitor, or an NRI, and this is used in the treatment of attention deficit hyperactivity disorder, or ADHD, in children, adolescents, and also with adults. So the black box warning was established in 2005 because of reported increased suicidal ideation in children and adolescents. This emerged in those clinical trials. The meta analysis leading to the warning found a rate of 0.4% for suicidal ideation in pediatric patients when taking atomoxetine, and that was compared to 0% in the placebo group. Now, unlike stimulants, things like methylphenidate or amphetamines, atomoxetine does not carry a risk for abuse or dependence, and that's what makes it a preferred option in some specific cases. The clinical implications that you need to be aware of as a prescriber is we want to screen for baseline suicidal ideation, and that's before prescribing, especially in children and adolescents. We want to monitor for worsening mood, increased irritability, or suicidal thoughts during the first few weeks of treatment or after any dose adjustment. We want to consider alternative treatments, potentially a stimulant instead if they have ADHD, could be behavioral therapy as well. So, this is in patients with any type of history of suicidality or severe mood swings or changes. Now, with the parents and caregivers, we should educate them about the warning signs. We just talked about the agitation, aggression, new and worsening depression, or social withdrawal means mood swings. And then we do that weigh risk versus the benefit. So, untreated ADHD is associated with higher risks of substance use, academic failure, and self harm. So, does the risk outweigh the benefit or vice versa? A case study involving atomoxetine we'll take a look at real quick with a 12-year-old male who has ADHD. Initial treatment is atomoxetine 40 milligrams daily with a follow up at week 3. And during this week 3 follow up, the child's mom reports he has become more withdrawn, is frequently tearful, and has expressed feelings of hopelessness. Mental status exam revealed depression, passive suicidal ideation in the form of, I wish I weren't here, and limited insight, unaware of changes in his own mood. The intervention that we do at this point in week 3, so we want to discontinue atomoxetine immediately, and then we want to switch to a stimulant like methylphenidate, 10 milligrams, extended release daily. We initiate CBT. We monitor those moods weekly at this point. And then at follow up, so we're looking at about week 6 here, we should see a resolve of the suicidal thoughts. And we should also see ADHD symptoms improving with that stimulant therapy that we started the patient on. Let's go ahead and move on to bupropion or Wellbutrin. So, this does have an associated black box warning. First of all, we have increased risk of suicidal thoughts and behaviors in young children. And some of the background that we see here is this is a norepinephrine dopamine reuptake inhibitor. So, this is what we call an NDRI, and it is used for major depressive disorder, seasonal affective disorder, and off label use for ADHD. In 2004, an FDA meta analysis, they did conduct this research, which led to the antidepressant black box warning to include bupropion for that increased risk of suicidality in the younger population. Now, while bupropion is considered activating, it can exacerbate anxiety, agitation, and impulsivity in younger patients, which may also contribute to increased suicidality. Now, as far as the clinical implications for prescribers is concerned, we want to avoid in patients with high impulsivity, severe anxiety, or bipolar disorder due to that increased risk of mania induction. We want to monitor closely for worsening mood or emergent suicidality, especially during the first 4 to 8 weeks. We want to consider alternative antidepressants, so something like an SSRI first, in younger patients with higher suicide risk. We want to dose this medication cautiously in order to minimize agitation and the side effects. So, some of the examples that we're talking about here are Wellbutrin IR, which is the immediate release formulation. We have Wellbutrin SR, or the sustained release, and Wellbutrin XL, the extended release of this medication. All right, so some of the risks for serious neuropsychiatric symptoms when used for smoking cessation, because this can be utilized for that as well. All right, so bupropion, it is FDA approved for smoking cessation, but reports surfaced of neuropsychiatric effects can include things like severe mood changes like depression, agitation, or anxiety, hallucinations and delusions, hostility and paranoia, and also suicidal ideation and attempts can occur. So, this black box warning went into effect in 2009. This was added for both bupropion and Chantix. Okay, this is due to reports of those severe neuropsychiatric reactions. So, history of the psychiatric disorders for MDD, anxiety, and bipolar disorder is going to need to be assessed as a risk factor for the neuropsychiatric symptoms. Also, ongoing alcohol use should also be looked at as well, and rapid dose increases or normal initial doses that are higher. So the black box warning update in 2016 was due to inconsistent findings in clinical trials. So the neuropsychiatric warning was removed for most users, but prescribers, we want to still monitor for any type of behavioral changes that we see in this patients. Okay, let's talk about a quick patient profile for bupropion. We have a 45-year-old male with a history of depression and past nicotine dependence. So, initial treatment was bupropion sustained release, or SR, 150 milligrams daily for smoking cessation. Now, the patient has shown up again for his follow up at week 4. He's reporting severe paranoia, saying things like, I think people are following me. He's having visual hallucinations and also irritability. He denies drug or alcohol use, and he has no prior history of psychiatric symptoms. So, what's going on here? Based on what we learned, right? So, the intervention is going to be to discontinue bupropion immediately, and we need to switch to a nicotine replacement therapy, or NRT, plus behavioral support. This is because we're having unfavorable side effects and reactions to bupropion. All right. So symptoms, they should resolve in about 10 days of discontinuation of this medication. And we are going to need to perform a psychiatric evaluation for psychosis as well. All right, moving on to antipsychotics, and we're gonna split one out from the others because it does have some significant issues that we need to talk about, and a lot of black box warnings associated with it. So we'll talk about clozapine or clozaril first, and then we'll roll into all antipsychotics, both first and second generation. All right, so first up is clozapine or clozaril. So this is an atypical or a second generation antipsychotic. We'll call them the SGAs, primarily used for treatment resistant schizophrenia. and reducing suicidality in schizophrenia or schizoaffective disorder. So while it is the most effective antipsychotic for treatment-resistant cases, it carries multiple FDA black box warnings due to the life-threatening adverse effects of this drug. All right, so first black box warning we're going to talk about is severe neutropenia or agranulocytosis. So this is found in about 1 to 2% of patients. Risk factors that are associated with agranulocytosis and clozapine are going to be things like fatal infections, sepsis, pneumonia, fever of unknown origin. The definition of severe neutropenia is going to be an ANC of less than 500, but a normal ANC is typically above the 1500 mark. So 1500 is where we're looking at. Anything below that, we're going to start to be concerned. And it does require an immediate discontinuation. So monitoring protocols here are going to be put into place here through the REAMS program. So due to that risk of agranulocytosis, the FDA mandates enrollment in a clozapine risk evaluation and mitigation strategy, or REMS program, for each patient. So we're going to see baseline absolute neutrophil count of the ANC before starting treatment, and then frequent monitoring of ANC. So first 6 months, we're going to be doing this weekly. Months 6 to 12 afterwards are going to be every 2 weeks. And then after 12 months, we're looking at monthly. So remember, we want to discontinue immediately if the ANC is less than 500, and then monitor for signs of infection, fever, sore throat, and flu-like symptoms. If any of those things pop up, you want to go ahead and discontinue it even before you get the laboratory studies back, because it's going to be obvious there's some type of infection. Now, for purposes of the exam, we're going to use that 1,000 cutoff to go ahead and discontinue and get laboratory studies. All right, next black box warning that we have associated with clozapine is going to be seizures. So this is a dose-dependent risk, especially at doses greater than 600 milligrams a day. So we do see an estimated risk here at the 3 to 600 milligram daily level of about 3% seizure risk. Greater than 600 milligrams, we jump up to 5% seizure risk. We also can identify the myoclonic jerks. These are going to be an early warning sign of pending seizure activity. We want to avoid in patients with epilepsy or those with a high risk, so head trauma, alcohol withdrawal, and CNS infections. Risk reduction strategies here, we want to slow the titration down, starting at 12.5 milligrams a day. Then we divide the doses to reduce peak plasma levels, monitor for myoclonic jerks or an EEG abnormality, and then we use prophylactic anticonvulsants. So things like VA are preferred over carbamazepine, and that's due to the increased agranulocytosis risk that already persists and is present with carbamazepine. Number 3 black box warning is going to be myocarditis and cardiomyopathy. So incidence rates here are going to be about 1 in every 500 patients. So onset is usually within the first 8 weeks of treatment, and symptoms are going to include fatigue, chest pain, dyspnea, palpitations, tachycardia, and fever. And then we see elevated C-reactive protein, or CRP, and elevated troponin levels within the blood laboratory studies. Diagnosis, we're going to use an echocardiogram. We're going to look for those ECG changes, and then, of course, the noted troponin elevation. Now, the monitoring recommendations for the myocarditis and the cardiomyopathy are going to be checking that baseline CRP and troponin, monitoring weekly for the first 8 weeks, and then we want to discontinue immediately if we suspect or find myocarditis. Our 4th black box warning, this is going to be orthostatic hypotension, bradycardia, and syncope. So clozapine carries a high risk during the initial titration for these issues. Risk factors are going to include rapid dose escalation, the elderly patient population specifically, concurrent antihypertensive therapy that you're already or the patient is already on, and then low baseline blood pressure as well. So some of the risk reduction strategies we can utilize for this black box warning are going to be initiating at a 12.5 milligram a day dose, and then we're going to titrate that slowly. We want to divide doses to prevent that blood pressure fluctuation. And then also let's monitor for blood pressure closely during any type of dose increase. Okay, so final one here we're going to talk about our black box warning number 5 for clozapine is going to be increased mortality in elderly patients with dementia related psychosis. All right, so some of the key points and takeaways here. All antipsychotics, including clozapine, are going to carry this particular black box warning. So risks that are associated are going to be increased cardiovascular risks, things like stroke and sudden death, and an infection like pneumonia or sepsis. So the FDA does not approve clozapine for dementia-related psychosis, and we want to look at alternative treatments available. So non-pharmacological interventions should be prioritized in this population. All right, so managing those clozapine adverse side effects. Let's take a look at a case study here. This is James T. He's a 34-year-old that has been diagnosed with treatment-resistant schizophrenia. His history includes a failed trial of olanzapine and risperidone and no history of seizures or cardiac disease. So the treatment plan that's implemented is clozapine, initiated at 12.5 milligrams a day. And then remember, we're enrolling him in the REAMS guidelines or REAMS program, and we do weekly ANC monitoring. Now, the patient comes in at week 4 for a follow up. He's already complaining of fatigue and fever, sore throat. You draw some blood, and we have an ANC of 900 cells per mm cubed. So it was previously at 2,600. Your CRP is 5.5, and that is elevated. So, what do we do for our interventions here in this particular case? First thing we want to do is discontinue clozapine immediately. And this is because of that increased and that high risk and probability of agranulocytosis. Second, we want to more than likely admit the patient because we need to do IV antibiotics due to suspected neutropenic fever, and then psychiatric reassessment for alternative treatments. So we want to consider maybe a long-acting injectable antipsychotic in lieu of the clozapine. Okay, so what are some of the clinical best practices for PMHNP considering this? We're going to assess that ANC at baseline and follow the REAMS monitoring requirements. We're going to start at 12.5 milligrams a day, then increase gradually to reduce the side effects. Educate patients on early signs of agranulocytosis, myocarditis, and orthostatic hypotension. Use alternative antipsychotics in elderly patients with dementia. Monitor for seizure activity, especially at doses greater than 600 milligrams a day. All right, so that's specifically looking at clozapine, clozaril. Okay, now we're going to go ahead and move on to all antipsychotics. This includes both first generation and second generation, and their associated black box warnings. Increased mortality in elderly patients with dementia related psychosis. All right. So a little bit of the background and the rationale for this black box warning. In 2005, the FDA issued a black box warning for all antipsychotics, including first generation antipsychotics and the second generations. And that was due to that increased risk of mortality in elderly patients with dementia related psychosis. Now, this warning was based on a meta analysis of 17 placebo controlled trials, which showed that elderly patients with dementia related psychosis who were treated with an antipsychotic had a 1.6 to 1.7 times greater risk of death compared to those on placebo. Now, causes of death were primarily cardiovascular in nature, so heart failure, sudden death, or stroke, or there was some type of infection like pneumonia or sepsis. So, the pathophysiology, why are antipsychotics risky in elderly patients with dementia? First and foremost, we have this increased risk of stroke and cardiovascular events. So, antipsychotics, particularly the SGAs, have been associated with increased stroke risk. This is both ischemic and hemorrhagic. Now, the mechanism we're dealing with here is increased platelet aggregation, endothelial dysfunction, and metabolic effects that contribute to thrombotic risk. Second, we have an increased risk of infections like aspiration pneumonia or even sepsis. So, antipsychotics cause sedation and impaired swallowing reflexes. So, leading to this potential of having aspiration pneumonia. Impaired immune function in elderly patients further increases that risk of infection. Number 3 is QT prolongation and sudden cardiac death. So both FGAs and SGAs can cause QTC prolongation, and this leads to something called dorsage de pontis, or sudden death will occur. High risk drugs are going to include Haldol, ziprasidone, and thorazine. Number four is orthostatic hypotension and falls. So antipsychotics block the alpha 1 adrenergic receptors, and this leads to orthostatic hypotension and increased risk for falls. Now, falls can lead to hip fractures, traumatic brain injuries or TBIs, and hospitalization. And then finally, we have worsening cognitive decline. So, antipsychotics increase dopamine blockage in elderly patients, and this could potentially worsen cognitive impairment with those that already have dementia. So, which medications are affected by this? So, like we said, all first generation are typicals and second generation atypicals. They carry the same black box warning. So, for first generations or your typicals, these strong dopamine 2 antagonists carry a higher risk of extrapyramidal symptoms, or what's known as EPS, QT prolongation, and cardiovascular risks. So, high potency FGAs or higher risk for EPS are going to include things like haloperidol, fluphenazine, and navine. Low potency FGAs, these are going to carry higher risk for sedation and hypotension. So, this is thorazine, and we also see this with thioridazine, which is strongest QT prolongation risk. Now, second generation antipsychotics or SGAs, these are your atypicals. So SGAs block dopamine, and this is the key factor here, 5-HT2 alpha serotonin receptors. This is going to carry lower EPS risks, but there's a higher metabolic risk associated with it. So you're going to see things like metabolic syndrome. So second generations commonly used in dementia, despite their warning. We do see Risperdal. This is most commonly used for dementia-related aggression. It does carry the lowest metabolic risk here. Quetiapine or Seroquel, this is preferred for Parkinson's disease psychosis, lowest EPS risk. Olanzapine or Zyprexa, we have high sedation and metabolic risks. Aripiprazole or Abilify, this is lower risk of QT prolongation, and it's less sedating than other second generations. So some of our higher risk SGAs, these are the ones that we're going to avoid in elderly patients. So clozapine or Clozaril, this is the highest risk for agranulocytosis, myocarditis, and seizures. And then ziprasidone or Geodon, this is high risk for QT prolongation. So some of the clinical implications for you as a PMHNP is you want to avoid any routine use of antipsychotics for dementia-related psychosis. So some non-pharmacological interventions should be the first line treatment for behavioral and psychological symptoms of dementia or BPSD. So use only if severe agitation, aggression, or psychosis poses a risk to the patient or to others. Second, we want to consider alternative treatments when possible. So, for aggression or agitation, we can use de escalation techniques, environmental modifications, and caregiver training. For depression and anxiety, we could consider SSRIs like sertraline or citalopram, which have a lower risk than other antipsychotics. For insomnia, we want to avoid sedating SGAs, and then we want to consider some low dose trazodone or melatonin instead. Now, the use of lowest effective dose for the shortest duration is going to be a really important concept here. If any antipsychotic is absolutely necessary, we want to use the low dose first and then frequent reassessment of that patient. So, next, we want to monitor for adverse effects. Okay, so check for ECG, QTC prolongation, metabolic labs like glucose and lipids, and orthostatic blood pressure. Watch for aspiration pneumonia, sedation, worsening cognitive decline in these patients. All right, so let's go ahead and take a look at a case study associated with antipsychotics and dementia. So, our patient profile we're going to talk about here is going to include Mary L. She's aged 82 years old. She's been diagnosed with Alzheimer's disease with behavioral disturbances. So, severe agitation, paranoia, verbal aggression, and this aggression is towards caregivers. All right, medical history is hypertension, type 2 diabetes, and a history of falls. Her current medications are lisinopril and metformin. Now, with initial management, non pharmacological approaches were used first. So we looked at caregiver education on de escalation techniques, structured routine and familiar environment, and then increased daytime activity to improve sleep. Medication trial with this was then utilized after those non pharmacological treatments and those measures had failed. So, in this case, we're going to use risperidone, Risperdal, zero point 0.5 milligrams nightly. This is a low dose initiated. All right, monitoring plan for this is going to be weekly assessments for sedation, falls, cardiovascular changes, and worsening cognition. Labs we want to check here are going to be metabolic panel, fasting glucose, lipids at baseline, and then at 12 weeks following. ECG for QTC intervals at baseline due to that risk factor of hypertension and diabetes. So, our follow up at week 4 is going to demonstrate this significant decrease in paranoia and aggression. And we're also going to identify minimal sedation and no new falls. And that's what we are expecting to see at that 4-week follow up. Okay, the plan moving forward here would be to continue at lowest effective dose for no more than 12 weeks and then attempt to taper off that medication. And so that's going to be a good example of what we would do for an antipsychotic use in a dementia patient. So, best practices for PMHNPs definitely want to assess risk before prescribing, and we want to avoid any routine use in dementia. Next, we want to use non pharmacological interventions first, followed by monitor for sedation, falls, infections, and metabolic effects. Remember to always use the lowest dose for the shortest time if medication is required, and then regularly attempt to taper or discontinue the medication. Okay, let's move on to our next medication here, which is lithium, our black box warnings associated with toxicity. All right, let's talk about those rationales and reasons for this medication to receive a black box warning. So, first up, we have lithium as a mood stabilizer, right? It's used primarily for bipolar disorder, for both acute mania and for maintenance therapy. It is also used for depression. So, an FDA black box warning was associated with lithium toxicity because it can cause severe neurotoxicity, irreversible renal damage, cardiac dysrhythmias, and even death. There is a very narrow therapeutic index here, so it requires frequent blood level monitoring. So toxicity is going to occur at levels greater than 1.5 milliequivalents per liter, with severe toxicity showing up at around 2.0 milliequivalents per liter or greater. So, the mechanism of action we see with lithium toxicity, first, we have renal excretion. So, remember, lithium is excreted unchanged, okay, by the kidneys, and it competes with sodium for reabsorption in the proximal tubule. Sodium depletion is going to increase lithium levels. So, dehydration, sodium restriction, or a diuretic such as some of the loop diuretics that we've talked about are going to increase lithium reabsorption, and that's going to cause toxicity overall. Then there's renal impairment. This is because of reduced clearance and it increases toxicity risk. So, any type of chronic renal damage or kidney disease. Now we see the effects on the CNS and the cardiovascular system. So, neurotoxicity, this is where lithium interferes with neurotransmission and neuronal function. And this is what causes tremors, confusion, and seizures. Then we have the cardiac toxicity. So, lithium alters intracellular potassium and sodium exchange. This leads to QT prolongation, bradycardia, or even ventricular dysrhythmias. So, some of the risk factors that we are going to be looking at with lithium, first and foremost, is dehydration and sodium depletion. So, vomiting, diarrhea, excessive sweating, heat exposure, fever, or excessive exercise, low sodium diets or excessive water intake, and then use of sodium wasting diuretics like thiazides or some type of loop diuretic. Then we have drug interactions that we have to watch out for because it can increase lithium toxicity occurrences. First up, like we said, diuretics, so thiazides, loop diuretics, these are going to increase renal reabsorption of lithium. Then we have NSAIDs, things like ibuprofen, naproxen. This is going to reduce renal clearance and increase lithium levels. ACE inhibitors and ARBs, lisinopril or losartan, This is going to reduce lithium clearance. And then SSRIs, TCAs, and antipsychotics. These can actually increase neurotoxicity without increasing lithium levels when we're taking them at the same time. Number three, we're going to talk about the renal impairment, so CKD or chronic kidney disease, regular aging, or nephrotoxic drugs that are going to impair lithium clearance. Long term lithium use can lead to interstitial nephropathy and chronic kidney disease or CKD. So, some of the clinical presentations that we're going to see with lithium toxicity, first of all, we're going to see mild, about 1.5 to 2.0, resulting in nausea, vomiting, diarrhea, hand tremors, dizziness, and muscle weakness, leading to moderate toxicity, 2.0 to 2.5, ataxia, slurred speech, confusion, coarse tremors, myoclonus, ECG changes like T wave flattening or QT prolongation. And then severe toxicity greater than 2.5, we're going to see seizures, delirium, encephalopathy, coma, dysrhythmias, and acute kidney injury. So this, as it goes up higher and higher, we start getting into the threes, then we could potentially have death as well. So the clinical implications for you as the PMHNP, first and foremost, we have to monitor protocol for safe lithium use. This is your baseline labs. So, renal function, you got to check BUN, creatinine, and EGFR. Electrolytes, sodium, potassium, calcium, and magnesium. Thyroid function tests, so TSH and T4, because lithium can affect your thyroid. And then ECG, so if greater than 40 years old, or there's some type of cardiac history, you want to go ahead and get that ECG. Then there's ongoing monitoring. So we're going to check those lithium levels every 5 to 7 days after dose changes, every 3 to 6 months for maintenance therapy. Renal function, so BUN and creatinine, we're going to check those at baseline and then every 3 to 6 months. Thyroid panel, again at baseline, and then every 6 to 12 months because of that risk of hypothyroidism. Patient education, this is going to include teaching the patient about hydration and diet. So, drinking 2 to 3 liters of water per day, avoid excess caffeine and alcohol. So, both of these can dehydrate the patient and alter their lithium levels. Do not restrict dietary sodium unless it's advised by a a collaborating physician or FNP. Recognize the early signs of toxicity. So you're going to be looking for nausea, tremors, diarrhea, and confusion, and you want the patient to report those immediately. Dose adjustments and drug interactions here. So we're going to see that you need to teach them about avoiding those NSAIDs, thiazides, ACE inhibitors, ARBs. We want to switch to something like acetaminophen for pain. And then adjust lithium dose in renal impairment. So if we have an EGFR of less than 60 mLs per minute, we want to reduce we're going to go ahead and reduce that dose in order to prevent any further complication. Onto our lithium toxicity management case here. So we have John D., who's a 50-year-old man. He's been diagnosed with bipolar 1 disorder and currently on lithium therapy, about 900 milligrams per day. Medical history includes hypertension, chronic kidney disease at stage 2, and current medications are lithium, lisinopril, and ibuprofen. This is for PRN back pain. The patient presents with the chief complaint of, I feel weak and dizzy and my hands are shaking. History here is we started taking ibuprofen more frequently over the past week, experiencing persistent nausea, diarrhea, and difficulty walking. Vital signs that were obtained were blood pressure of 100 over 65, so he was hypotensive, and a heart rate of 55, so bradycardic. Labs, we have lithium level at 2.4, we have creatinine at 1.8, and we have an ECG of prolonged QT intervals. So these labs tell us that the patient is at a toxic level and that there is acute kidney injury occurring. Management for this patient, first and foremost, we want to discontinue lithium immediately. Move on to IV hydration with normal saline, 0.9% NaCl to enhance that renal excretion. Discontinue ibuprofen and lisinopril because both of these impair lithium clearance. Then we got to monitor renal function and lithium levels about every 6 to 12 hours during this crisis. If lithium is greater than 4.0 or there's severe symptoms like seizures and comas, we do have to initiate hemodialysis. And then six, we'll restart that lithium at a lower dose after there is a full recovery with close monitoring by the care team. All right, we're moving on to our carbamazepine or Tegretol, black box warning here. So, this medication, Tegretol, is an anticonvulsant and it's a mood stabilizer. It's used to treat bipolar disorder, epilepsy, and trigeminal neuralgia. So, despite its effectiveness, it does carry some serious safety concerns, leading to multiple black box warnings. So, let's go ahead and dive into, what warnings we see here and what complications could be lingering or showing up for these patients. So, first, we have aplastic anemia and agranulocytosis. So, carbamazepine, this can cause severe bone marrow suppression, leading to life threatening aplastic anemia and agranulocytosis. The incidences here are going to be aplastic anemia, 5 to 8 cases per million patients, agranulocytosis, higher risk in the first 3 months of treatment. And the mechanism of action we're seeing here is Tegretol suppresses bone marrow cells, and this is going to reduce that red blood cell production, white blood cell production, and platelets. Risk factors: age, 60 years of age and older, any history of bone marrow suppression, or concurrent use of other myelosuppressive drugs like chemotherapy or clonazepam, and then pre existing hematologic conditions. So, some of the monitoring guidelines that we need to pay attention to here is going to be a CBC with differential. And this is going to happen before starting and then monthly for first 3 months and then every 6 months afterwards. Reticulocyte count at baseline. And then if the patient becomes symptomatic, we want to do a peripheral blood smear at baseline. And then if any abnormalities appear, ongoing. Clinical signs of aplastic anemia and agranulocytosis is going to be fatigue, pallor, weakness, and this is all due to anemia. Recurrent infections, fever, sore throat due to neutropenia, and then easy bruising, petechiae, and bleeding. And this is often due to that thrombocytopenia. So, management of hematologic toxicity, this is going to see discontinuation of Tegretol immediately if the white blood cells are less than 3,000 or an A1C, an ANC of 1,500. Supportive care with antibiotics or neutropenia, transfusions if necessary, and then consider alternatives to mood stabilizers like Depakote, lamotrigine, or even going back to lithium if we need to. Okay, second black box warning is going to be severe dermatologic reactions. This is Steven Johnson syndrome and toxic epidermal necrolysis, or TEN. So, SJS and TEN, these are life threatening hypersensitivity reactions with high morbidity and high mortality rates. Risk increases in patients carrying the HLA B1502 allele, which is more prevalent in Asian populations. Carbamazepine-induced SJS-TEN usually occurs within the first 8 weeks of therapy. Genetic screening and recommendations. So remember here, the FDA recommends genetic screening for anyone of the Asian descent or population for that 1502 allele before starting Tegretol. If the patient is positive for the 1502, we need to avoid Tegretol and consider some type of alternative like Depakote or lamotrigine. So, some of the clinical presentations we see with SJS. So, early signs are going to be in the first 1 to 3 days. We're going to look at fever, sore throat, conjunctivitis, and malaise. Then it jumps up to skin lesions appearing at days 4 to 7, painful macules, and progressing to bullae and desquamation. Severe stage TEN, this is when it progresses to greater than 30% of the body surface. Widespread skin necrosis, mucosal involvement to include the eyes, the mouth, and the genitals. Now, management for these conditions are going to be to discontinue carbamazepine at first sign of rash. We want to admit them to a burn unit for supportive care, especially in more advanced cases. And then fluids and electrolyte management. IVIG is going to be implemented, and cyclosporin may be helpful in those severe cases as well. Okay, next up we have Tegretol drug interactions and metabolism. So CYP450 autoinduction. Carbamazepine is a potent inducer of 3 alpha 4, leading to autoinduction or increases its own metabolism over 2 to 4 weeks. This reduces drug levels over time, requiring dose adjustments. Then we have drug to drug interactions. So, oral contraceptives, this decreases effectiveness, increased estrogen metabolism, and increasing the risk of pregnancy. We have warfarin. This is going to decrease anticoagulation effects with increased warfarin metabolism. We have Depakote and fluoxetine, going to increase carbamazepine levels because of inhibition of metabolism and increasing that risk of toxicity. All right. And then we see complications with antibiotics like erythromycin, clarithromycin. We're going to see increased carbamazepine levels, increasing that risk of toxicity. For our case study here of Tegretol, we have Emily R. She's a 28-year-old bipolar 1 disorder patient with manic episodes. Medical history is no significant past history. Genetic testing is positive for the 1502 allele. Now, the treatment plan here, carbamazepine is avoided due to genetic risk of SJS. Alternative treatment, we're going to look at Depakote, 750 milligrams per day with baseline CBC, liver function tests, and pregnancy tests before initiation. Now, follow up at week 4. We're going to say this is the case where the patient did receive Tegretol if the patient had tested negative for 1502. Complaints of my throat hurts, I have a fever, there's a rash all over my chest. You're going to have to do a physical examination. We're going to discover a high temperature. We're going to look at a rash spreading from the chest to the arms, and then mild mucosal involvement like oral ulcers. Labs are going to demonstrate a white blood count of 2,800 mm cubed. So this is low or neutropenia. And then platelets are going to be at 110. Management for this patient is going to include carbamazepine discontinuation immediately. We need to admit this patient to the hospital for supportive care, administer IV fluids, systemic corticosteroids, and wound care initiation. Patient recovers but requires lifelong avoidance of Tegretol and then anything structurally similar to that type of drug like oxcarbazepine, phenytoin, and lamotrigine. Our best practices for PMHNPs with Tegretol, we're going to screen the Asian population and patients for the HLA-B 1502 before starting, monitor CBC regularly to detect any early signs of bone marrow suppression, educate patients about early signs of rash, fever, and bruising, use alternative mood stabilizers like Depakote, lithium, or lamotrigine if that risk is elevated or present, and then monitor for any drug interactions due to that CYP 3 alpha 4 induction. All right, let's go ahead and move on to Depakote. So, Depakote is also known as valproic acid or VA. It's a broad spectrum anticonvulsant and a mood stabilizer. It's used to treat bipolar disorder, acute mania, and also maintenance treatment, epilepsy to include partial and generalized seizures, as well as migraine prophylaxis. Now, despite its efficacy, Depakote does carry 3 major FDA black box warnings due to life-threatening risks. First is going to be hepatotoxicity, second is fetal harm, and third is going to be acute pancreatitis. First up, with hepatotoxicity or that risk of fatal liver failure, it's most common in children under 2 years old, those with mitochondrial disorders, and patients on polytherapy with other anticonvulsants. Now, the onset is within the first 6 months of treatment, and the mechanism of action that we're dealing with here is Depakote inhibits mitochondrial function, and that's what's leading to hepatic necrosis. Now, the risk factors, again, are going to be children under the age of 2. That's the highest risk group. Those with mitochondrial disorders, polytherapy with other anticonvulsants like lamotrigine, phenobarbital, and anyone with a pre-existing liver condition. So clinical presentation of hepatotoxicity or early signs are going to be pretty nonspecific, but can include lethargy, malaise, anorexia, jaundice, vomiting, abdominal pain, edema, and also coagulopathy or that increased INR-PT. Second up, we want to talk about the liver function tests that need to be performed with hepatotoxicity. So we're looking at LFTs, Aston alt, bilirubin, and alkaline phosphate. We want to get it at baseline before starting Depakote and then ongoing every 2 weeks for the first 6 months, then every 6 months after that. We want to check ammonia levels at baseline if there are risk factors that are presented, and then ongoing if encephalopathy symptoms appear. Next is coagulation panel. So that'll be your INR and your PT. You're going to grab that at baseline. And then if bruising or bleeding develops, we want to go ahead and check it then. Now, there is some key management points to make with hepatotoxicity. So we want to discontinue immediately if signs of acute liver failure like jaundice or encephalopathy, INR greater than 1.5 occur. We need to monitor those ammonia levels for Depakote-induced hyperammonemia, and then L-carnitine supplementation. So can either be IV or it can be oral as well, and it may reduce toxicity in overdose cases. Okay, the next black box warning that we want to talk about is going to be associated with fetal harm. So this is major congenital malformations and neural tube defects. So teratogenicity risk with Depakote is one of the most teratogenic psychotropic medications out there. Absolute contraindication in pregnancy unless there is no alternative available for the patient. So the incidence of major congenital malformations is about 10%, and that's compared to 2 to 3% within the general population. So it's very high. Greatest risk is going to occur during that first trimester. Now, fetal Depakote syndrome is going to include those neural tube defects like spina bifida, encephaly, and myelomeningocele. Facial dysmorphisms, so this is going to be your wide nasal bridge, your epicanthal folds, and a cleft palate. We see congenital heart defects as well as cognitive impairment and autism spectrum disorder. So some of the key counseling points for women of childbearing age are going to include avoiding Depakote in pregnancy unless there's no other risk or no other treatment exists. Use effective contraception, so things like IUDs, oral contraceptives, and depot injections can also be utilized. If no alternative is present, we want to supplement with high-dose folic acid, and this is going to help reduce the neural tube defects. Then we also need to do prenatal screening, so maternal alpha fetal proteins, or AFP, and fetal ultrasound at 16 to 18 weeks in order to check for those neural tube defects. So some of the alternative medications for women of childbearing age that we may be able to consider are going to be with bipolar disorder, Lamictal or lamotrigine. Could even consider low-dose lithium. Of course, those all carry risks themselves. With epilepsy, we could be looking at lamotrigine or Keppra, as well as migraine prophylaxis with propranolol and Topamax. All right, moving on to the next, we have acute pancreatitis. Again, this is a life-threatening condition. So the onset can occur anytime during treatment, even after years of stable medication management and dosing. So this is a direct pancreatic toxicity. This is going to lead to inflammation, necrosis, and hemorrhage. So the mortality rate is up to 25% if it goes untreated. Clinical presentation of pancreatitis is going to include severe epigastric pain that radiates to the back, persistent nausea and vomiting, elevated serum amylase and lipase, systemic inflammation to include fever, tachycardia, hypotension in those severe cases that present. So management of pancreatitis is going to include discontinuing Depakote immediately if pancreatitis is suspected. We want to offer supportive care like IV fluids, pain control, and electrolyte correction. And then we monitor for systemic complications like shock and multi-organ failure. Let's dive into a case study dealing with Depakote. We have Sarah W. She's a 32-year-old bipolar 1 disorder patient. No significant comorbidities, and Depakote is at 1,000 milligrams per day. Now, at follow-up at week 6, her chief complaint is, I feel nauseous and my stomach hurts a lot. Symptoms are severe upper abdominal pain that radiates to the back, persistent nausea and vomiting, no fever, but tachycardic with a heart rate of 110 beats per minute. Laboratory studies indicate amylase at 600, lipase at 800. Those are both elevated, and LFTs are normal. So what are we going to do for this patient in this case? First, Depakote is discontinued immediately due to suspected pancreatitis. Patient is admitted for IV fluids, pain control, and close monitoring, and then we transition to lamotrigine for mood stabilization. All right. So, what are some of the best clinical practices we can utilize as PMHNPs? Quick review here. We always order baseline LFTs, pregnancy test, and CBC before therapy. We monitor liver function, coagulation, and ammonia levels routinely. We educate women of childbearing age about pregnancy risks and also contraception. We recognize early signs of pancreatitis. That's going to include abdominal pain, nausea, elevated amylase and lipase. And we discontinue immediately if hepatotoxicity or pancreatitis is suspected. Next up, we have Lamictal or lamotrigine. We do have a black box warning here associated with life-threatening skin reactions like SJS and TEN. So a little bit of the background here, lamotrigine or Lamictal, it's an anticonvulsant and a mood stabilizer. It's used for bipolar disorder, maintenance therapy, but it is preferred in bipolar 2 disorder. It's also treating epilepsy, partial and generalized seizures, as well as LG syndrome. So FDA black box warning here is risk of severe life-threatening skin reactions. This is going to include Stevens-Johnson syndrome and toxic epidermal necrosis. So incidence rates here, we see SJS about 1%, so 1 in 1,000 adults, and TEN in about 0.03, so 1 in 3,000 adults. There is mortality rate associated with SGS, approximately 5 to 10%, or TEN, we jump up way higher with 30 to 50%. So let's talk about the mechanisms of actions here. Hypersensitivity reaction. So lamotrigine is going to affect T cell activation and also the immune response. And that's what leads to these keratinocyte apoptosis and epidermal necrosis. This occurs within the first 2 to 8 weeks of treatment, and the risk increases rapidly with dose escalation or any co-administration with Depakote. All right, risk factors that we're dealing with here are going to be high initial dose or rapid dose titration, ongoing use with Depakote. So Depakote inhibits lamotrigine metabolism, and that's going to increase the levels. History of hypersensitivity reaction to anticonvulsants. Children under the age of 16 years, this is a higher risk for severe rash. And HLA genetic susceptibility, so that B1502 allele in the Asian population. All right, so the clinical presentation of SJS and TEN. For the early stage, days 1 through 3, fever, sore throat, conjunctivitis, malaise, and fever-like symptoms. Then we see skin lesions appear at day 4 to 7, so painful, these macules that progress to bullae and desquamation. Severe stage is going to be your TEN. This is widespread epidermal detachment. This is when we have greater than 30% body surface area affected. We also have mucosal involvement with the eyes, the mouth, and the genitals. So the key distinguishing feature here is rapidly progressing, painful blistering rash with mucosal involvement. Prevention strategies, how do we reduce these risks? We want to have a slow titration, so standard dosing schedule. With week 1 to 2, we're at 25 milligrams a day. Then we increase weeks 3 to 4 to 50 milligrams a day. Week 5, we go up to 100 milligrams a day. And then week 6, 200 milligrams a day. That's going to be our target dose for bipolar disorder. So if co-administered with Depakote, we start at 12.5 milligrams a day. That's half that standard dose. And that's because we want to prevent toxicity. We avoid co-administration with Depakote if possible. So remember that Depakote inhibits lamotrigine metabolism, so doubling its plasma levels. Obviously, that's going to increase and have a higher risk of SJS and TEN. If using both, remember that we have to reduce or decrease lamotrigine by 50%. We educate our patients about the early symptoms, so stop immediately at the first sign of a rash, fever, or flu-like symptoms. Do not restart lamotrigine after SJS or TEN develops because of cross-sensitivity risk. Genetic screening in high-risk populations, so your HLA B1502 allele testing recommended for Asian patients before initiation, and then if positive, avoid lamotrigine, higher risk of SJS, TEN. Now, the management that we need to look out for SJS and TEN is going to include discontinuation of lamotrigine immediately if any rash develops. Hospital admission required for SJS and TEN cases. We're typically going to send them to the burn unit if it's a severe case. Supportive care with IV fluids, electrolyte management, and wound care. Avoid corticosteroids in SJS and TEN. This may increase the mortality risk. And then we can use cyclosporin or IV immunoglobulin or IVIG in those severe cases. So let's talk about our case study with this medication recognizing SJS. So our patient here is going to be Daniel R. He's a 27-year-old with bipolar 2 disorder. Medical history, there's no prior history of rashes or any known drug allergies. And his current medication is lamotrigine, 50 milligrams a day. That's at week 3, and sertraline, 50 milligrams a day. At follow-up week 4, he has a chief complaint of, I have fever and my skin feels like it's burning. His symptoms that present are 101.8 fever, malaise, a sore throat, painful red rash on the trunk and upper extremities, mild oral ulcers and eye irritation, and no prior history of drug allergies. What is our intervention for a patient presenting at week 4 with these complaints while taking lamotrigine? First things first is we're going to discontinue lamotrigine immediately, and then we have to admit this patient to the hospital for monitoring of progression of symptoms. We offer supportive care with IV hydration and electrolyte maintenance and management. And then the patient is transferred to a burn unit as lesions progress to involve greater than 10% of the body surface area. So, what is our expected outcome here if we do all of these things? Well, the patient should recover after about 2 weeks of supportive care. But remember that he's advised to never take lamotrigine again due to cross sensitivity risks. All right, so best practices, clinical takeaways for the PMHNP. Remember to start slow, and titrate slowly. 25 for the first 2 weeks, slower if they're taking Depakote. Educate those patients about early warning signs of SJS and TEN. Screen for high-risk populations, Asian descent for HLA B1502. Discontinue immediately if any rash appears, and never restart lamotrigine after SJS or TEN is discovered. Next up, we have stimulants, and we'll talk about the black box warning associated with this. So a little bit of background on stimulants. So stimulants include amphetamine, dextroamphetamine, or Adderall, and we also have others like Vyvanse, methylphenidate, or Ritalin, Concerta. They are the first-line treatment for ADHD and narcolepsy. Despite their efficacy, though, they do carry a black box warning due to high potential for abuse and dependency because it is a Schedule II controlled substance. And we also have serious cardiovascular events, including sudden death, stroke, myocardial infarction, hypertension, especially in patients with some type of underlying heart condition. All right, so let's talk about how the mechanism of action works here. So there is a high potential for that abuse and dependency. So stimulants increase dopamine and norepinephrine levels, which enhances attention, focus, and impulse control. However, dopaminergic stimulation in the reward pathways, remember the ventral striatum and the nucleus accumbens, this increases addiction potential. So chronic use can lead to tolerance, which is the higher doses needed to get that same effect. Dependence, okay, and this is your withdrawal symptoms like fatigue, depression, and irritability, as well as addiction, so cravings and compulsive use. So let's talk about the risk factors here. Anybody with a history of substance use disorder or SUD, adolescents and young adults like college students, athletes, professionals that are out there seeking performance enhancement, high dose or non-prescribed stimulant use. So we can see this for crushing and snorting, IV use, polydrug abuse with alcohol or benzodiazepines. So some of the clinical recommendations here we have to prevent abuse would be assessing for risk before prescribing. So we want to use screening tools like the KH8 or the DAS-10. We start at the lowest effective dose and avoid high dose escalation. We can use long-acting formulations like Concerta or Vyvanse to reduce the abuse potential. And then we want to monitor prescription refills. Also, we need to perform urine drug screens if we become concerned about the possibility of misuse. Our next one we need to talk about is the cardiovascular risk. So there is a risk of sudden death in patients with structural heart disease. So stimulants increase heart rate. This is about 5 to 10 beats per minute, and blood pressure about 2 to 10 mmHg. which can be a dangerous combination in patients with any underlying cardiovascular disease. So, reports of sudden cardiac death and myocardial infarction, or MI, and stroke have been documented in patients with undiagnosed heart conditions. So, stimulants may cause arrhythmias by increasing catecholamine release and excitability in cardiac tissue. So, some of the high risk conditions for sudden cardiac death are going to be structural heart defects, hypertrophic cardiomyopathy, and congenital heart disease. Arrhythmias like long QT syndrome, Brugada syndrome, and we also have the Wolff Parkinson White syndrome. Now, we have a history of syncope or unexplained fainting episodes, uncontrolled hypertension or severe tachycardia, and finally, personal or family history of sudden cardiac death. All right, some of the cardiac screening before prescribing a stimulant needs to include baseline blood pressure and heart rate. We want to monitor at follow-ups. Detailed cardiac history that includes finding out about syncope, palpitations, chest pain, unexplained sudden deaths in the family. We want to consider ECG if there is a history of fatal heart disease or arrhythmia, both in the patient and in family members. If high risk, refer to cardiology evaluation before we initiate any type of stimulant use. So, which stimulants carry this type of warning? It's going to include both the amphetamine-based and methylphenidate-based stimulants. All right, so let's jump into our case study here of stimulants. We have Jacob T. He's a 16-year-old male, ADHD combined type. Our medical history here is mild hypertension, so we have a blood pressure of 135/88 and a family history of sudden cardiac death. His uncle died at age 32. Medication history, there's really not any. So current treatment plan, we have prescribed Adderall, extended release, 10 milligrams daily. At the week 4 follow-up, the patient has a chief complaint of, I feel like my heart is racing and I get dizzy when I stand up. Physical exam shows 148/95 for blood pressure. This is elevated from his baseline. His heart rate is now at 98%. Again, this is tachycardic. There is no heart murmur that's heard or any reports, but there are intermittent palpitations by the patient. An ECG is performed, and we have normal sinus rhythm with a QTC of 460 ms. So that's kind of a borderline prolonged situation. So in a case like this, what would we do for this young man? First of all, Adderall XR should be discontinued immediately due to those cardiovascular concerns. Then referral to cardiology evaluation because there's a concern for underlying condition or an abnormality. And then we can offer alternative treatments. So atomoxetine, for example, or Strattera. This is a non-stimulant ADHD medication. We're going to initiate that instead of the Adderall. So our expected outcome, if we follow this kind of treatment plan, would be to see the patient with no further cardiovascular symptoms or when he's on atomoxetine. And we want to see those ADHD symptoms are going to remain well controlled even after switching to atomoxetine. Okay, our best clinical practices regarding stimulant use. Remember, assess cardiac history and blood pressure before prescribing stimulants. Avoid stimulants in patients with arrhythmias, structural heart disease, or uncontrolled hypertension. Non-stimulant alternatives can be utilized like atomoxetine, guanfacine, clonidine. We could even consider Wellbutrin if there's some type of cardiovascular high risk. Monitor closely for signs of stimulant use, dependence, and tolerance. And then finally, we have to educate the patient and their family members on those cardiovascular risks and the early warning signs. So things like palpitations, chest pain, dizziness, or fainting. Okay, our next drug class we're going to look at are going to be the benzodiazepines, and we have a serious risk here for respiratory depression, abuse, and other life-threatening withdrawal complications. So benzodiazepines are sedative hypnotic drugs that act on GABA A receptors to produce anxiolytic, hypnotic, anticonvulsant, and muscle relaxant effects. They are primarily used for your anxiety disorders, insomnia, seizure disorders, muscle spasms, and also alcohol withdrawal. Now, despite their therapeutic effects, benzodiazepines do carry those black box warnings. So we see that risk of respiratory depression, especially when combined with other opioids. Um, High potential for abuse, misuse, and addiction due to their rapid onset and reinforcing effects. And then three, we have severe life threatening withdrawal symptoms, including seizures and delirium. All right. So we talked about those key FDA warnings for benzodiazepines. We're going to jump into some clinical implications and why we really have to pay attention and proceed with caution when prescribing and monitoring our patients that are on a benzodiazepine medication. And we have to pay particular attention to those special populations. So, first up, we're going to talk about the risk of depression. So, risk of respiratory depression, particularly when combined with opioids. So, benzodiazepines, they act as a central nervous system or CNS depressant, potentiating GABA A activity, and that's going to lead to sedation, respiratory depression, and coma at high doses. So, the greatest risk when combined with opioids, alcohol, or other CNS depressants. Okay, so the mechanism here again, benzodiazepines reduce the brainstem respiratory drive by increasing GABAergic inhibition in the medullary respiratory centers. Synergistic depression of the respiratory drive occurs when combined with opioids, which act on mu opioid receptors in the brainstem. High risk populations are going to be your older adults, your older patients greater than age of 65. This is because of increased sensitivity to slower hepatic metabolism. In patients with COPD, sleep apnea, or obesity, this is because of that hypoventilation syndrome that can occur. Polypharmacy users, so those on opioids, barbiturates, alcohol, and muscle stimulants, and also a history of substance use disorder, this is going to increase the likelihood of misuse with the benzo. So, the clinical recommendations we have here, we want to avoid co prescribing benzodiazepines with other opioids whenever possible. Consider alternative treatments for anxiety or insomnia in those high risk patients. We have to educate patients on the signs of overdose. This is going to include respiratory depression, cyanosis, and confusion. And then we can prescribe Narcan or naloxone for patients to use when they are prescribed a benzodiazepine or an opioid. All right. Second one we're going to look at with the benzos is going to be a high potential for the abuse, misuse, or addiction. So all benzodiazepines are classified as these Schedule IV controlled substances, but they still carry a significant risk of dependence and misuse. Risk of highest for short-acting, high-potency benzodiazepines like alprazolam and lorazepam. Chronic use leads to tolerance, requiring higher doses for the same effect, increasing the risk of misuse. Which benzodiazepines have the highest risk potential? Let's talk about those abuse potentials real quick. So, alprazolam or Xanax has about a 6 to 12 hour half life, so it's a very high, rapid onset abuse potential. Lorazepam or Ativan, we're looking at a 10 to 20 hour, so it's pretty high as far as abuse is concerned. Diazepam or Valium, that's going to be a 20 to 50 hour, so that's a moderate abuse potential. Clozapam or Klonopin, that's your 18 to 50, so again, moderate. And temazepam or Restoril, that's going to be 10 to 20 hours, moderate. And we typically use this medication for insomnia. Now, Xanax, it does have the highest abuse potential due to that rapid onset and short half-life. This is because it results in the faster reinforcement of its use. Signs of benzodiazepine complications and addiction are going to be escalating doses beyond the prescription. We're looking at doctor shopping to obtain multiple prescriptions, using benzodiazepines with alcohol or opioids, cravings, and compulsive use, withdrawal symptoms when stopping suddenly. Clinical recommendations that we need to look out for here is going to be assessing for substance use disorder before prescribing the benzodiazepine. And then we want to really use the lowest effective dose for the shortest duration. So less than or equal to 4 weeks recommended. To be honest with you, I'm looking at about a 14-day use. All right. So, number three is the life threatening withdrawal symptoms such as seizures, delirium, and psychosis. So, with the management of benzodiazepine withdrawal, we really have to focus in on how chronic benzodiazepine use leads to physical dependence and abrupt discontinuation, and how it results in these withdrawal symptoms. And again, these can be very life threatening. So, withdrawal symptoms usually begin within 24 to 48 hours and peak at 5 to 7 days. Mild to moderate withdrawal symptoms, this is anxiety rebound. We're looking at seizures. We're looking at insomnia, restlessness, irritability, increased heart rate, mild tremors, and sweating. Then, when you get into the severe withdrawal symptoms, these are going to be your life threatenings like seizures. This includes grand mal and tonic clonic, delirium, leading to hallucinations, confusions, and agitation, psychosis like paranoia, auditory or visual hallucinations, and autonomic instability or hypertension, tachycardia, and hyperthermia. So, the highest risk of withdrawal seizures occurs if a patient has been on a benzodiazepine for greater than 3 months and then stops immediately. So, benzos with the highest risk for withdrawal seizures are going to be Xanax, 6 to 12 hour half life. Remember, so we've got a very high risk here. Lorazepam or Ativan, 10 to 20 hours. So, again, high. Diazepam or Valium, that's a 20 to 50 hours. So, we have a moderate risk for with seizures. And then clonazepam or Klonopin, 18 to 50 hours. It's going to be moderate. So really, the real go-to here is going to be a shorter half-life is going to equal a higher withdrawal risk. So for management of those mild withdrawal symptoms that we just talked about, the anxiety and insomnia, we want to taper slowly over weeks to months and then reduce by 10 to 20% every 1 to 2 weeks. We want to consider cognitive behavioral therapy for anxiety management. For the moderate withdrawal, like the tremors and the autonomic instability, so we want to substitute with a long-acting benzodiazepine like diazepam or clonazepam, and then we slow taper over 6 to 12 weeks. For severe withdrawal, seizures, delirium tremens, we do need to admit this patient to the ICU for IV benzodiazepine replacement, so lorazepam IV. We want to monitor vitals like blood pressure, heart rate, and temperature, and this is because we need to prevent autonomic instability. Then we need to consider phenobarbital if the benzodiazepine taper, in fact, fails. Okay, let's take a look at our case study here for the benzodiazepine. This is our last case study for this podcast. We have a patient whose name is Michael B. He's a 42-year-old male diagnosed with generalized anxiety disorder. Medication history includes alprazolam 2 milligrams TID for 5 years, prescribed by the PCP. Chief complaint continues to be, I ran out of my Xanax 2 days ago and I feel like I'm going to go crazy. Symptoms include severe anxiety, restlessness, sweating, tremors, heart palpitations, and auditory hallucinations, things like I hear whispers. So, what is our intervention for a patient presenting with these complications and this medication history? First up, the patient should be admitted for benzodiazepine withdrawal management. We do want to switch to something else, so we'll switch to diazepam because this is a long-acting benzo. And then we taper the patient off over 8 weeks. We're going to refer to CBT, so psychotherapy, to manage anxiety without the use of benzodiazepines. Our expected outcome in this type of scenario, once we put all of that into action, we should successfully discontinue the benzodiazepine, and then we successfully transition to an SSRI for long-term anxiety management. All right, best clinical practices for the PMHNP when dealing with benzos. Limit benzodiazepine prescriptions to short-term use, less than or equal to 4 weeks. In my opinion, 14 days is plenty. Avoid co-prescribing with opioids and alcohol. Screen for addiction before prescribing. Taper slowly to prevent withdrawal seizures. All right, so we're going to dive into our conclusions here and how we navigate these risks and benefits and dealing with black box warnings. So black box warnings, they serve as that critical safeguard to ensure that you, the clinician, make informed prescribing decisions while prioritizing patient safety. Throughout this discussion, we've examined high-risk medications commonly used in psychiatric practice, including antidepressant, antipsychotic, mood stabilizers, stimulants, and benzodiazepines, remembering that each of these carry a serious, potentially life-threatening risk if not properly managed. Now, as PMHNPs, our role is to balance therapeutic benefits with potential dangers. And this is going to help ensure that patients receive evidence-based, individualized treatment plans. This requires thorough risk assessment, patient education, and proactive monitoring to mitigate the adverse effects. Okay, so our key takeaways from today: recognize the clinical significance of black box warnings and integrate safety precautions into practice. Screen patients carefully before initiating high-risk medications, particularly for cardiovascular disease, pregnancy, history of substance use disorder, and genetic predisposition, so HLA-B1502 for carbamazepine. Educate patients and caregivers about warning signs, potential adverse effects, and when to seek emergency care. We want to monitor lab values, the vital signs, and mental status regularly. This is to help identify any of those early signs of toxicity, withdrawal, or medication-induced syndromes, things like lithium toxicity and Stevens-Johnson syndrome, or TEN. Use the lowest effective dose for the shortest duration possible. And this is really going to be important when we're dealing with our older population. And we want to explore and use alternative treatments when a safer option is available. We need to advocate for de-prescribing when appropriate, so to reduce the risks associated with long-term medication use. This is because of benzodiazepine dependence and stimulant misuse. All right, so my final thoughts here. While black box warnings highlight serious risk, they do not prohibit the use of these medications. Instead, they're guidelines, right? They guide responsible prescribing and risk mitigation strategies. So when we understand the risks and we look at how beneficial or not the medication would be, then we can have proactive conversations with our patient, their families, as well as the interdisciplinary care team for the patient. So the ultimate goal here is to enhance patient outcomes while minimizing harm, reinforcing the importance of ongoing education, clinical vigilance, and patient-centered care. So by staying informed, adhering to safety guidelines, and applying sound clinical judgment, PMHNPs can confidently navigate the complexities of prescribing these high-risk psychiatric medications. All right, we would like to thank everybody and give you a quick reference table for summarizing all these black box warnings that we've discussed. If you have any clinical making guides out there, you definitely want to use those when selecting safer alternatives for high-risk patients. It's been a pleasure being with you here again today. This is Dr. Rossi with the PMHNP Podcast. See you next time. Bye-bye.